is this thing right here. And it's implanted under the skin, attached to the muscle on your abdominal wall. And when we want to make an adjustment to the band to change the amount of restriction, to make it a little tighter, then we take a needle that goes through the skin into the port, and we inject saline, which then the saline makes its way to the band that's built into the balloon, I should say, that's built into the band. It inflates the band and changes the diameter. That's a good question. The question she's asking is, what's the recovery time, I think? You say downtime, but how long does it take you to recover for it? And that's going to vary a little bit from person to person, and it depends on what you're recovering to do, right? Are you recovering to, run a marathon, or are you recovering to go back to do a desk job? And so it's an outpatient procedure, and honestly, I don't have a problem with anyone going back to work as soon as they feel ready. But honestly, most people will take at least a week off from work. Most people, I would say. But that doesn't mean you have to. I mean, you're going to be a little bit uncomfortable because there are incisions, and the place that's usually the most sore is right where we put that port, because you stitch it into the muscle. And so that's going to be sore for a little while. If you can put up with some soreness and things like that and do your job, then I don't have a problem with you going back, having it on Friday and going back to work on Monday. The next procedure that I want to talk about is sleeve gastrectomy. And I would guess that many of you have heard of sleeve gastrectomy now, but some of you may not have heard of it. It's a relative newcomer. In fact, of all the surgeries I'm going to talk about today, it's probably the newest. Now, having said that, a sleeve gastrectomy is part of a duodenal switch, which I'm also going to talk about today. Okay, so the sleeve gastrectomy is the restrictive part of a duodenal switch. And as you can see in the slide, part of the stomach is removed. So you see the light shaded part of the stomach there in the slide. And if you can read the labeled area, it says excised stomach. That means it's removed. Okay? And we do that with a stapler. And the way the procedure is performed, it is performed laparoscopically. We put a guide down through the stomach and place it along what we call the lesser curve of the stomach, this side over here. And that gives us a gauge of how much to remove. And then we take a stapler and we staple along that guide. And then we divide all the blood vessels to that part of the stomach and we take it out. Okay? So it is a restrictive operation in that we're making the stomach smaller. A couple of things that would differentiate this from lap band. It's a purely restrictive operation. We would still consider it less invasive than maybe some of the other surgeries, but now we're looking at a permanent change to your body, right? So we might consider it a little bit more invasive than lap band, because once we take that part of the stomach out, you can't put it back in. An advantage that it may have over a band is you're not putting a device in there that could erode into the stomach, or that could slip, or that needs to be adjusted. Okay, and so that may come down to a personal thing, personal preference. Some people want something they can adjust. They like the fact that you put a band in there and I can adjust this. Some people may not like that. Some people say, I don't want to have to, that's a hassle. I don't want to have to go to the doctor every 6 weeks for a year or whatever it turns out to be and get a needle put in and get this adjusted. But they accomplish things in a similar fashion. They're both purely restrictive. They're designed to decrease the amount of food that you eat at each meal, and they also have a similar weakness, again, that I mentioned earlier about restriction, and that is that you still have to eat 3 meals a day and not 1, okay, starting in the morning when you get up and ending when you go to bed. But it is becoming more popular, and I think that myself and a lot of my colleagues are very enthusiastic about it because I think it's going to give us another option, again, another option that is a little less invasive that will fit the needs of some of our patients. Her comment is that she's concerned that after we do this surgery that the stomach could stretch back out, okay? And this brings up a really kind of a whole topic with me that I'd like to, that I'll cover. And that is the idea that when people have this kind of surgery and they gain weight back, that it's always because their stomach's stretched out, okay? 'Cause that's the layman's way of looking at it. And it's a way that doctors can blame their patients for bad results. Oh, you stretch your stomach out. But the reality is, I'll just tell you, because I've been doing gastric bypass surgery for 12 years. So I've seen a lot of things in the long term. And I've seen patients who have ultimately put weight back on and failed. I think what happens most of the time is that you don't really stretch the stomach out so much. It's just you just develop new bad eating habits of snacking frequently, eating, junk and midnight snacks and all those kinds of things that over time add up. But in terms of stretching out, I don't know that that's really a big factor. But I can tell you, and we're going to go over a little bit later on, that the 4 to 5 year results are very as good as, and maybe in some cases a little better than lap band. So I think it's a very comparable procedure. Okay, so that's kind of the way I would present to you now. It's a purely restrictive operation that appears to give equivalent results with lap band, but it's a different approach. The question is, does this, really what you're asking is this a longer recovery than lap band? I would say yes, it is a little bit longer recovery from lap band. And one reason I would say that is this: with lap band, we're going to put the band on, and then you're going to leave the operating room, and it's going to be empty, and you're going to be on a liquid diet for 2 weeks, and you're not going to be able to tell much difference. All you're going to have is some pain from the incisions and a little discomfort and things like that. But other than that, you won't really know anything's done. With this, when you leave the operating room, you got the most restriction you're ever going to have. So we've just taken out about as much as 70 to 75% of your stomach. And you're going to go home on a liquid diet maybe for a few days, and then within a week usually we're going to have you start on some soft foods, and you're going to know at that point, or before that point, yeah, something's different. And so I think that part of it makes the recovery a little bit different. So we do like to keep our patients in overnight because we want to make sure that they're going to be, they got all that restriction, make sure they're going to be able to tolerate their liquids, that they're not going to have, too much nausea, and obviously look for any signs of leakage or anything like that. I would say that in general the weight loss will be a little bit faster with this early on, and that's because you got all that restriction right up front. And it's going to take us a little while to get the band to catch up on the restriction. So the lap band patients will tend to start off a little bit slower, and then they have to catch up on the weight loss. The duodenal switch, as I said earlier, has been around since the early 1990s. It was a modification of a surgery that's been around since the early 1980s. If you remember the slide when I first started talking about surgery, we're kind of grouped in little boxes. There was a word there called biliopancreatic diversion, which is a long word and kind of a mouthful. In the 1990s, some surgeons here in the United States made a modification to that surgery, and the modification basically is how the stomach was removed, what portion of the stomach was removed, and how you hooked it back together. Now this is still considered a biliopancreatic diversion. It's just a second generation, if you will, of that procedure. The reasons for the modification, just so you understand, were to try to eliminate complications related to hooking the intestine directly to the stomach, and we'll talk about that a little bit when we talk about gastric bypass. Doing the duodenal switch, we preserve there's a valve at the bottom of the stomach called the pylorus, which slows the emptying of the food from the stomach, And the duodenal switch preserves that valve and allows the food to stay in the stomach a little bit longer. And so duodenal switch patients generally won't get dumping syndrome. Make it sound like I think dumping syndrome is a really bad thing, and some people do. But what I do tell my patients is if you have a sweet tooth and sweets are really your downfall, there's only one surgery that I do that can help you with that, and that's gastric bypass. Because if you get dumping syndrome and you feel bad when you eat sugar, then you probably won't eat so much of it. Remember, I told you earlier that your food and your nutrients are absorbed in your small intestine, okay? And so if we want to create malabsorption, we don't want you to absorb all the calories that you take in, then we have to modify the small intestine. In this case, what we're doing is bypassing the majority of the small intestine. So in addition to the sleeve gastrectomy that I talked about earlier, we're going to divide the small intestine just below the stomach, the area we call the duodenum, which is the very first part of the small intestine. And then I'm going to come down to the colon, the large intestine right here, where the small intestine and the large intestine come together. And I'm going to measure back up a certain distance. And just so you know, in general, that's about 250 centimeters. Again, we're a metric system. And I'm going to divide the intestine there, in the lower part of the small intestine. And then I'm going to take that and I'm going to hook it to that duodenum right here. So I'm going to bring it where it was hooked up down lower. I'm going to bring it up here and hook it here. So now the food is going to go through that small stomach, through here, and through this part of the small intestine, which we'll just say right now roughly makes up about 40% of the small intestine, okay? The other part of the small intestine now is bypassed. There's no food going through it. But the bile that comes from the liver and the enzymes that come from the pancreas come through there, okay? So remember that term we call biliopancreatic diversion? We're diverting the bile and the pancreatic enzymes into this second limb, the bypass limb. And it's going to come down through here, and we're going to hook this back together right here at about 75 to 100 centimeters above the colon, okay? And so what that's going to do is it's going to create malabsorption. And the malabsorption is occur from two basic mechanisms, or two basic principles. One is that you have a shorter part of the intestine to work with, okay? So now you're working with only about 40% of the small intestine. And the other thing is that, guess what the bile and pancreatic enzymes do? They help you digest your food, okay? Particularly your more complex foods. It's sort of the end of the digestive system, okay? But the bile helps you absorb fat, and the enzymes from the pancreas help you break down fat and starches and proteins and things like that that are more complex. The enzymes break the chemicals down to the point where they can be absorbed into the bloodstream, okay? This surgery can be done laparoscopically, and in almost all cases I will do it laparoscopically. This would be considered the most invasive surgery that I do, or that's being done for weight loss. And I will tell you right now that it is also the most effective surgery that's done for weight loss. Again, that doesn't mean that I think it's right for everyone, okay? And I think that, as we'll see later, I think it's, if you're super obese, remember we talked about, the BMI, I think depending on where you're starting, you're super obese, then I think, that this is a procedure that you should probably consider, or at least look at and evaluate. Because as we'll see later, it does cause more weight loss. But there is also some additional risk. Okay. Again, the question is recovery time. How long in the hospital, how long to get back to work or normal activities. And because it's more invasive, you expect that to be a little bit longer, and it is. I generally keep most of my patients in the hospital 3 nights. And I'd say everyone's heard of gastric bypass, but some people might say, well, what about the Roux-en-Y procedure? Well, that's what this is. Okay, Roux-en-Y gastric bypass. And this is what I got started with back in the mid-1990s. And so I've been doing this longer than I have any of the other surgeries. Today, I do them all laparoscopically. And it's still a very good and very effective procedure, but like the other procedure, I mean, it has some drawbacks. It's not a perfect operation, right? So that's the way I want to present it to you. It involves dividing the stomach. And so this part of the stomach is called a gastric bypass because this part of the stomach that you see on the slide here, the majority of it is going to be bypassed. But we're going to leave it in place. We're not going to remove it, okay? But we are going to divide the stomach with a stapler. And then we're going to come down below the stomach and we're going to measure down a little ways from the top down. And we're going to divide the intestine. And we're going to bring that into the intestine up and we're going to hook it to the little stomach that we created there at the top, right here. And then we're going to reconnect this right here. Now it's called Roux-en-Y procedure because you kind of get this, you get these two limbs that come into one, and like a Y does, okay? And that's where it gets the name Roux-en-Y. And so you have this part of the stomach that we leave in place, but it's still going to have some secretions. And again, you're still going to have the bile and the pancreatic enzymes coming into the duodenum, which we've bypassed. And so all of those have to come back into the intestinal tract at some point, and we're going to hook that back together right here, okay? And that's a Roux-en-Y gastric bypass. So it has a restriction of that small stomach. And it has some degree of malabsorption because we are going to bypass a part of the small intestine, and we're going to have a part of the small intestine here that doesn't have the bile and the pancreatic enzymes. Now, the thing that differentiates that significantly from that other surgery we just talked about, remember what it's called? Biliopancreatic diversion? Okay, the main thing that's going to differentiate, there are a couple of things that are going to differentiate. One is the size of the stomach, but the main thing is how much of the intestine is actually bypassed. In this case, the amount of the intestine that's bypassed is generally a fairly small amount. As you can see up here, the biliary limb, or we could call it pancreatico-biliary limb, is only usually about 2 feet, okay, which is a relatively small percentage of the small intestine. Remember, in the duodenal switch, and I know I'm using these terms interchangeably, duodenal switch, biliopancreatic diversion, that portion of the intestine is going to be the majority of the intestine. So we have much less of the intestine bypassed here than we do, and so we're going to have a lesser degree of malabsorption. Okay. Now we can vary that depending on how much of the intestine where we divide the intestine and how we hook it back together. If you remember, if you look back to the slide when we first started talking about surgery, we had our little blocks, you know, and you'll notice under gastric bypass it has short limb and long limb. Okay, and what that's telling us is that we can modify the gastric bypass a little bit to try to suit the needs of an individual patient. It's not like a lap band where you adjust, you know, make individual adjustments according to the patient, and it's only a one-time thing at the time of surgery. But what we typically do is if someone has a higher body mass index or they're starting at a higher level of obesity, we will generally make those limbs a little bit longer, okay, and bypass a little bit more of the intestine to add a little bit more malabsorption, okay? But generally we don't do that to get the degree of malabsorption that you would get with the duodenal switch surgery. This fits all into the schema thing in the spectrum as being a little bit more in the middle, okay, really in terms of how invasive it is and in terms of we're altering the body quite a bit, but it's not quite as malabsorptive. So we'd say it's a little bit less invasive than duodenal switch, okay? Recovery time is going to be probably a little bit quicker than duodenal switch, probably more similar to what we see with sleeve gastrectomy, okay? little bit quicker recovery on average in most cases. Hospital stay, I'm just thinking the questions you guys are getting ready to ask, okay? It's okay. Hospital stay, I usually keep most of my patients 2 nights in the hospital, although it's very common these days for people to stay 1 night and go home the next day. And I think your question is, you're trying to get at, well, how does that functionally work between the different surgeries? Because you're right, we're talking about restriction 3 different ways, right? In one, we've got a smaller stomach, we've removed part of the stomach. In one, we've bypassed part of the stomach. In another, we put a band around the stomach. And that's true. I mean, we are trying to accomplish, there are different ways of sort of accomplishing the same thing. There are going to be some differences. Again, this is not something I can adjust. It is reversible. Okay, I mean, I can put it back. And some people think it's not, but I haven't taken really anything out, so I can put it back and reverse it. Now, having said that, I can tell you that the reoperation rate for gastric bypass is significantly lower than it is for lap band. There are some studies out there showing reoperation rates, band explant, meaning you take the band out, rates of 20% or greater. And that's a pretty significant number. Okay, again, not saying that to put down lap band, but just trying to give you the information in general in terms of weight loss. And we're going to go over this when we go over results, how much, kind of compare those. But in general, lap band patients lose slower, again, because we don't tighten the band right at first, and we tend to kind of gradually tighten it over time. Whereas with operations like sleeve gastrectomy and gastric bypass, you get all that restriction right after surgery, and so the weight loss is faster at first. There's no question that the weight loss is faster with gastric bypass, sleeve gastrectomy, and duodenal switch than it is with lap band in the first 6 months to a year. But again, the most important thing is not necessarily how fast you lose it, but the amount you lose and whether you maintain that waist in the long term. Remember, to me, the long term is the most important. Okay, so I don't see that as a reason not to have lap band, because the weight loss is a little slower at first. And for some people, they want that. I mean, I do have some patients say, I really want the weight loss to be gradual for whatever reason. With gastric bypass, sleeve gastrectomy, duodenal switch, I generally have my patients on liquid diet for about a week, okay? And then they begin to progress through what we call puree diet, mushy diet, sort of mushy diet, soft diet. I mean, there is a progression, and that information is information that you get very much more in detail, and specifically if you come and see me and go through our program and we're going to do your surgery. But yes, there is a progression of diet, and we try not to make them too different between the surgeries. But for instance, lap band patients are on liquid diet for 2 weeks after surgery. I have a lot of colleagues that put all their patients on liquid diet for 2 weeks before surgery. I don't generally do that unless I really need to see some weight loss before surgery. Then we might do something like that. But as a general rule of thumb, I don't put my patients on a liquid diet. We may want to make some modifications to their diet beforehand, but we don't usually do a liquid diet as a rule of thumb. Okay. Anytime we do surgery, I mean, there's a chance of complications. And this is just kind of a list of common things, right? And so all these surgeries, or any abdominal surgery that you might have, would have a risk of having a problem with the incisions or the wound, infection, a hernia, or the common things that we see. And we don't see those very commonly with laparoscopic incisions. In fact, that's where we see one of the biggest improvements in laparoscopic surgery is these incisions are small, so they don't get infected very often. You don't generally get hernias, and they don't hurt as bad, right? And those are all good things. But you can still get an infection. You could get a hernia, and that's why we do caution our patients about lifting real heavy things right after surgery. Give it some time to heal, and so we can still see some wound complications, although we don't see nearly as many as we see if we make a big, say, 8-inch incision. Complications involving the lungs can be related to the fact that you don't breathe as well after surgery, because it does hurt. It hurts to cough, hurts to take a deep breath. Again, with laparoscopic surgery, that's less, and so we don't see as many patients who have difficulty breathing after surgery who require oxygen for prolonged periods as we do if we have a big incision and they just almost can't cough or they can't, breathe deep enough. So we don't see that as much, although we can see it to some degree. But another complication that is related to the lung that you've probably heard of before is actually a pretty serious complication in which a blood clot that may form in the legs can break off and go through the circulation into the lung. It's a complication we call pulmonary embolus. Pulmonary meaning the lung, and embolus meaning that something broke off and moved and got lodged, okay? So pulmonary embolus is actually the most common cause of death after surgery of all kinds. Not just weight loss surgery, but all kinds. And it can occur with any kind of surgery. Now we talk about it specifically with weight loss surgery because our patients are a little higher risk in general because of their weight, because of sometimes poor circulation, and because some of our patients don't move as well because of some disability. In other words, if they may be in a wheelchair, they just may not move around.